So my role today, as I see it, is to set up the panelists for a discussion about recent changes to Ontario's long-term care laws. I'm going to provide a short summary of the long-term care admission law in Ontario and how the Better Homes, Better Care Act and related amendments have sort of changed the legal framework to admission in long-term care in Ontario. So I will identify some legal issues with the changes, but I see we have Jane Matus here as well, so she may be able to provide more of an update there, but I will leave it to other panelists mostly to dive into the concerns. I want to start with a general legal framework for healthcare and long-term care admission decisions, because I think this context is important in terms of appreciating the significance of the recent legal changes. So as I go through my legal summary, I'm going to flag some sort of key legal terms in my mind, like consent, capability, risk, autonomy. Generally, admission to long-term care homes requires consent by the person who is being considered for admission, and if they are capable of making the consent decision by their legal substitute decision maker. Consent means an informed and voluntary agreement. The same is true for healthcare. It's basically my body, my choice. Our consent rights include a right to decline care and also to withdraw from care. Healthcare and long-term admission decisions have their roots in common law notions of battery. Ontario codified these common law principles under its Healthcare Consent Act and its Fixing Long-Term Care Homes Act, and it's the predecessors to that legislation. Also informed this right to informed and voluntary consent to admission to long-term care. Under these laws, people have a right to make a decision about whether to move into long-term care, and also to select a specific home with a vacancy if they are capable of that decision. And so what capability means, if you're capable, you can understand all the information relevant to that decision and you can apply it to your situation. And also you can appreciate the consequences of that decision. And often when we talk about consequences in healthcare settings and these assessments, we're talking about risk. You'll hear that word a lot. That is to say, do they understand the risks involved in staying in their long-time home as opposed to moving into a long-term care setting? For long-term care, people are basically choosing whether to kind of live independently in the community with whatever support is available to them in their unique circumstances. So friends, neighbors, family, private or publicly funded long-term care, volunteers, or to move into a facility or a home where you get 24-hour assistance and nursing care is available to you. This is almost always a significant and potentially life-changing decision for people and their families. And I think that's really important to remember. It means gaining care in exchange for a loss of autonomy and privacy. Lately, we have heard a lot of stories about how bad things can be in long-term care. So many people will not equate long-term care with safety guaranteed. Living at home can pose risk. Living in long-term care can pose other risks. Adults of all ages are entitled to make choices that create risk for them as long as they understand and evaluate those risks. They can do this, they can understand and can evaluate those risks in order to make, again, we go back to an informed decision. Often people choose to age at home even if they have a great risk of serious falls or other negative consequences because they value their independence, don't want to move, and they're comfortable taking that risk that they understand they're making. If they cannot understand those risks, then a substitute decision maker makes the decision for them, and that is probably a family member for most people. Often there will be disagreement about whether an older person understands the risks. Family may pressure them to move into long-term care. An older person's mental incapability may be assessed to determine if they can make that long-term care admission decision. That happens a lot in my experience. Although most healthcare and long-term care admission laws provide exceptions that allow care to be provided temporarily without consent in emergency situations, generally the my body, my choice rule applies until now. So how has long-term care admission law changed for Ontario? There are 3 areas where legislation changed to permit this new version of what some folks are calling a first available bed approach for Ontario. So first we have the Better Homes, Better Care Act, known as Bill 7. It changes the long-term care admission process for patients in hospital who are considered appropriate for discharge to long-term care. And it alters their consent rights. Bill 7 amends both the Fixing Long-Term Care Act and the Healthcare Consent Act in a few places. A companion regulation creates different approaches, a different process for patients considered appropriate for long-term care, and it impacts their confidentiality of their patient information significantly. There's also been amendments to the hospital management regulations, which require public hospitals to charge patients $400 a day if they are no longer in need of treatment in hospital. So usually the admission process in long-term care works something like this in Ontario. Roughly there are 3 steps after a person has expressed interest in long-term care. So a placement coordinator determines their eligibility for long-term care, which means considering their care needs. They assist the person to select a home. They approve admission if the selected facility is appropriate to their needs and the person is suitable to long-term care. The licensee, so the long-term care manager, will approve the admission. We were willing to take this person. And then the person or their substitute decision maker provides that voluntary informed consent to admission to that specific facility. Bill 7 creates different rules for adults in public hospitals. If an attending physician says they are ready for discharge from the hospital and they do not require what the law says is an intensity of resources or services provided in a hospital setting, and they may be eligible for long-term care. So you see this new language in Bill 7 that refers to patients who are called alternate level of care patients. So you may have heard that in the news, alternate level of care. Under the new provisions, the placement coordinator takes a number of steps regardless of whether a patient has expressed an interest in long-term care. So we're getting ahead of the application. They determine eligibility for long-term care. You know, they've always done that, but they do it without the application. And they do this based on an assessment by a physician and a nurse. They must try to get consent for the assessment, but it's not required. The legislation says make all reasonable efforts. They select a facility within the geographic range set out in the regulation, which I'll mention briefly in a moment. And they provide the long-term care home manager, the licensee, with information and the assessment. So this is confidential personal health information, again, without the consent of the person who might be moving to long-term care. And they authorize admission as they did in the past. The licensee would approve that admission and then potentially admit them when a bed becomes available. The new long-term care regulation identifies some very unique steps that are new. So the placement coordinator must provide certain information to the patient, including letting them know about relevant co-payments so that they will be charged for their hospital stay. That's that $400 I mentioned a moment ago, if they do not consent to the placement recommended by the coordinator. The regulation also identifies confidential information the coordinator may get access to in order to make the eligibility of the placement decision, and it requires certain people or agencies to provide that confidential information without consent. The regulation allows placement coordinator to select a home, even if the person is on a wait list for other facilities where they would like to live. And there's some guidance in the legislation about where the placement can be. So for folks in Southern Ontario, there's a radius of 70 kilometers in which the placement coordinator can select a home. And if for someone living up north, there's a 150 kilometer radius provided, but the legislation says that if there's no other spot, they can basically provide it with any vacancy that's in the whole province. So the combined effect of these laws does not allow a physical placement of the patient in long-term care without their consent. That's important to understand. There's no forced removal of the patient. However, the legislation creates a framework in which consent to long-term care admission can essentially be coerced by the healthcare system. Recall how I explained earlier that consent is at its core a voluntary and informed choice. The person must choose the bed offered by the placement coordinator, or they go back home where they may not have services set up yet, or they're going to be charged $400 a day to stay in the hospital. Patients also lose confidentiality in their health information. They don't decide how it gets shared. I cannot comment on how long this process takes in practice, but once the patient or their substitute decision maker receives the placement information and that kind of ultimatum, the law provides only a 24-hour grace period before they start getting charged $400 a day, regardless of their kind of financial capability to pay that fee. Now, I understand there is a charter challenge potentially in the works here, led by the Advocacy Centre for the Elderly and the Ontario Health Coalition. And I know Jane is here to say a few words. So I can just say that briefly, my understanding of how this might be approached is that one could argue that the Bill 7 and the regulations violate the Charter of Rights and Freedoms in at least a couple ways. So first, Section 7 provides for liberty and security of the person. And in the context of this new legislation, the person is essentially being kind of forced to live somewhere maybe away from their support people. It's quite a bit broad radius geographically. There's no true freedom to consent because there's a rush to make quite a life-altering decision in a difficult time when folks have been in hospital without time to set up home care. And such support might not be available in their community because there might not be home support available to them at all. The decision is arguably coerced and not alignment with other charter decisions about the right to voluntary and informed consent. There's a strong body of litigation in that area in Canada. We also have the Section 15 equality provisions of the Charter. I think you could argue that there's a form of ageism or disability discrimination baked into the law here because we have a context where older and frail people and potentially people with significant disabilities are subject to a different discharge planning framework and have different rights. And this is a vulnerable population as it is. There may be questions about whether the Canada Health Act is offended because Ontario is charging for services that are medically necessary and considered funded under the Canada Health Social Transfer. I don't know what might happen, but I think the most likely consequences would be that Ontario might have to repay some of this income it's getting from all these individuals. I'm not sure how this would play out and how realistic that is, but I think it's within the possibility. And I know Jane probably can't say this, so I just want to flag that this is a charter challenge by two nonprofit organizations. So I think at the end, you'll know more about these two organizations, and there's an opportunity to make donations to this campaign to make the charter challenge litigation possible. So I'm just going to pass it on to the other speakers to talk about their thoughts about the legislation. Thank you.
Thank you very much, Ms. James. So our second speaker is Dr. Samir Sinha. He is the Director of Geriatrics at Mount Sinai and University Health Network Hospitals in Toronto. He's also faculty at the University of Toronto and at Johns Hopkins University. Dr. Sinha, we'll hear from you now.
Thank you very much. Merci, and hello, everybody. A real, well, I wouldn't say a pleasure, but it's a tough conversation to have, and but I'm glad we're having this conversation today, so that we can talk a little bit more about what Bill 7 has come to represent. I have to say this is kind of the introduction and then the subsequent passing of this legislation is perhaps one of the kind of worst points, I would say, in my healthcare career here in Ontario, because I never thought that we would actually get to this point where we would actually start considering legislation that really, has already, been likened to the idea of structural coercion, where we're actually now stripping people's rights and forcing them potentially into situations and into a process that really is something that we're doing to some of our most vulnerable folks in our province. And so this was a very, very tough period for me over the last few months, realizing how quickly this could happen, and also seeing the reactions that I've seen just from the public, but also from colleagues as well, in terms of thinking this is appropriate, and me having a lot of moral distress, where I remember having one call with a colleague who's saying, you're making, the life of some of your colleagues, very difficult, because a lot of us want to get these patients out the door, and this is going to be helpful, this is going to be good, and so why are you causing such a ruckus? Because this needs to be done. And I just simply said that in this conversation that I'm sorry, but I took a Hippocratic oath, and that it's about doing no harm. And when I feel that people's rights are being taken away from them unfairly, I feel it's my duty as a physician to actually speak up about this. And when I realized that not all of my colleagues, within the healthcare system, within the hospital system, may share the same opinion, that becomes quite distressing to say, how are we looking at the same people in front of us? And when do rights matter, and when do rights not really matter? And could this lead to other things as well? So my colleague, Krista, just really helped to kind of lay out the technicalities of what Bill 7 really represents, and how many different kind of things had to change in order to allow Bill 7 to now exist. For example, changing patients' bills of rights, changing our healthcare consent Act, and changing traditional processes that have been sacred and well regarded as well. And I think the challenge with all of this is that it's not just a matter of making technical changes to legislation, but this has all been couched in a lot of political rhetoric as well, and a lot of political positioning, because this has been done within the context of a healthcare system that has been struggling greatly. And when we have a government in Ontario that has had a lot of other legislative options, has had a lot of other options in front of it, such as the idea of repealing Bill 124 that keeps wage restraint at 1%, or trying to regulate the issue of agencies charging exorbitant amounts to hospitals that kind of rob budgets for providing healthcare, but then also have a negative impact on our staffing overall. I really felt that in many respects, when Bill 7 was introduced, this really wasn't about trying to really improve the healthcare of people in Ontario, but rather trying to be a situation where we have our government trying to look like it's doing something when it was really doing something that, in my view, was not the most important thing that we could be doing to better improve the care that we're providing. So I just want to focus on a few things from a clinical perspective, because I think Krista really laid out what are the technicalities and how does this work. But fundamentally, we have to remember that the folks being affected by Bill 7, these are folks who are often in desperate situations, that often when we're talking about people who might be considered for long-term care from a hospital, from the point of a hospitalization. These are sometimes folks, for example, who might have been doing well in the community and then had a significant illness, and now have had a life-changing event that no longer allows them to be able to return home with existing or available resources to reintegrate that way. And so this might be the first time long-term care is being considered as a potential option. But then we also have other individuals who might have been struggling in the community, may have already been considering long-term care, but then something urgently has happened that has allowed them to end up in hospital, for example, and now we're starting to think about disposition planning and where we can go. So as Krista mentioned, sometimes folks who are in these positions where we're thinking about disposition, these may be people who are already familiar with the process, may have already made up to 5 choices and said, these are the homes that I want to go to, these are the homes where I may be willing to go to. And the challenge with Bill 7 is it almost allows hospitals to say, well, the choices that you have, we respect the fact that you've made those choices, but those choices aren't convenient for our wait times right now. We need to free these beds, and therefore we know that there is a home that's not on your preferred list of choices, and therefore we're going to choose that one for you. And in fact, we're going to get you an acceptance and move you right along. And so the fact that we have a situation where this legislation now can allow us in situations to not respect choices or now make choices without a person's input. And then, as Krista was saying, give them the right to refuse or the right not to consent to be forcibly removed from the hospital. Well, that's not really that's not really protecting a level of consent when the deal has already been done, and then you have the choice to refuse or be charged $400 a day. So it really does put us in a situation where you're taking incredibly vulnerable people in incredibly challenging situations, and then really having a power imbalance where hardworking healthcare professionals who are trying to do their best are now working in a structural system where two things in my view can happen. One is this can make things a lot more difficult to be able to have positive conversations with families or try and problem solve and work through and think about what needs to be done, because people say, well, whatever I want, does it really matter? Because ultimately you also have the upper hand. If I don't agree with what you want, or if you don't like my choices, you can always, force me to go where you want. And even though I can refuse to go, it's still going to result in a $400 a day charge. So in many respects, my concern is that this can poison relationships or poison important relationships that you want to develop when you're trying to have conversations around disposition planning, which is a really important and sacred process, and one that needs to be handled in a very delicate and thoughtful way. And so this is where I get very concerned about how this can really create challenging situations where people, where there is an incredible power imbalance, and why we've been using the term structural coercion. So the other challenge that I have with this bill is that when you actually look at the regulations as well, it's now also giving hospitals permission to start actually charging you, as I understand, the $400 a day. And I'm happy to be corrected by my colleagues. It's not only about decisions around long-term care placement, but that hospitals, according to the regulations that support the legislations, can now start suggesting other disposition planning options as well for you as well. So it's not just about whether or not you choose to go to a long-term care home, but also hospitals can start saying, look, we have other disposition plans that we want to provide. And the question becomes is, when you have now a legislative framework that allows hospitals to move people along quite easily and with good force to long-term care, the danger that you also have in terms of that second paradigm is I always wonder if in certain situations people might not want to work as hard to explore the other solutions, to do the hard work that it takes to try and get someone home, to start problem solving and figuring things out, when ultimately the challenge is that it's the easiest thing to do now is just simply to have that person move on to a long-term care home, as opposed to seeing what we can move and what we can build together to try and return that person back to the community or look at other options as well. So it's problematic because it creates a huge amount of moral distress. It creates a lot of moral distress again around clinicians who often are being put into these difficult situations, discharge planners that now have to start thinking about what are the other ways we want to do it, and most importantly, patients and their families. So I just wanted to share with you a little bit about that perspective that I'm thinking about, but now we can hear from some of my other colleagues as well.
Excellent. Thank you so much, Dr. Sinha. We'll now hear from our third panelist, Amy Hsu, she is an investigator at the Bruyere Research Center, a Research Institute, I should say, I apologize. She holds a U Ottawa Bruyere Research Institute Chair in Primary Healthcare and Dementia. Ms. Hsu.
Hey, thank you for that introduction, Louise. Good afternoon, good evening, everyone, depending where you're calling in from. First of all, thank you to the organizers for inviting me to this event with this incredible panel. I'm thrilled to be part of this conversation and to have the opportunity to discuss a really important issue and share some of the observations that I've made. And the topic that I really want to focus on top of what Dr. Sinha had just shared regarding concerns about violation of individual patients' right, is what's the implication of this new legislation, amendment to our legislation, on the health and the type of healthcare system that we're building or we're trying to build. So as you know, Bill 7 now has been enacted, known as More Beds, Better Care Act. I put a question mark there, ironically, of course, to highlight the fact that are we actually in fact providing better care for frail older adults in our population? And I put the definition of alternate level of care here just as a reminder of what initially this bill, when it was proposed, it was purported to resolve. So when we talk about patients in ALC, we're talking about individuals who remain in a hospital, but do not require the intensity of resources or services provided in the setting. But that doesn't necessarily mean that they cannot benefit or they do not need additional support. It just means that they cannot be discharged to a setting where appropriate support can be provided. And in fact, when we look at the data from across Canada, we see that the individuals who could benefit, so ALC patients were designated as ALC, remaining in hospital, who are waiting for services. The individuals who are waiting the longest to be discharged are in fact individuals who could be discharged to the community and benefit from more support and services provided in the community setting. So when we looked at the distribution of individuals waiting for placement in long-term care, that makes about 40 to 45% of individuals within ALC. And a large proportion are actually older patients. On average, an ALC patient, the average age of an ALC patient is around 83 years. So we are talking about a frail older adult population. They can in fact be discharged to the community with better supports. And what we also know, and this is data from 2017, so way before the discussion about this legislation, before the pandemic, what we've seen with data from across Canada is that patients who are hospitalized, so seniors who are hospitalized, they're more likely to be discharged to the hospital, to the long-term care if they were referred from the hospital. And even when they are at a lower level of need compared to their counterpart in the community. So what this graph illustrates is that, so for those who are not familiar with the MAPLE score, so MAPLE score is a risk assessment score we use in Ontario to determine eligibility for placement in long-term care. And what you see in this graph is that individuals who have a lower MAPLE score, so individuals who are actually potentially more functionally independent, who could be cared for in the home, actually enter long-term care at a higher rate and sooner than someone who has a higher MAPLE score in the community. So when we're talking about assessing the eligibility for admission into long-term care, I think we really need to think about who's providing oversight of that determination of eligibility. A large part of this is that because we're unable to support individuals in a home and community setting, that's a determining factor. So when you look at the risk factors for entry into long-term care, besides dementia, besides complex medical conditions, having no support in the community is one of the key drivers for why someone might enter long-term care. So what that tells me is in fact, we need to provide more support so that individuals can be discharged and supported in the community setting rather than being transferred to long-term care. So the risk here is that by enacting a legislation that allows essentially providers who often don't, they're not able to find adequate resources in the community, are essentially forced to make this decision to potentially place a patient into long-term care because there aren't enough supportive services that the patient can use and can benefit from in the community. So we're forcing clinicians to make these decisions because there aren't adequate models of care or resources that otherwise. And so in addition to the fact that patients are forced to potentially relocate to a home that is not their preference, to a home that is far from their social network, their care partners, their family members, we're also putting, like Dr. Sinha mentioned, clinician in this very difficult decision of putting individual here with very little guidance around the eligibility requirement. And so, in all this discussion about long-term care placement, what I also want to introduce is this consideration for equity and quality of life. So when we look at who is actually waiting for placement for long-term care in Ontario, this is data we have pulled from provincial level data from individual on the long-term care wait list. We see that those who are waiting for long-term care are in fact minority older adults who are waiting for placement in an ethnic or cultural specific home. So while currently, when we look at the ALC population, ethnic minorities do not make up a large proportion of our ALC patients, this could potentially affect the quality of life and the type of care that older adults who belong to ethnic minority group might receive in the future. So thinking long-term about the implication of such legislation not only impacts the rights and freedom of patients who are currently waiting for care, but also thinking about the fact that we're not creating more opportunities for more culturally appropriate homes that minority population, minority individuals might be waiting for. And so down the line, they may be forced to choose a home that's not appropriate and not aligned with their preference. And why does that matter? What we see is that, as I mentioned earlier, a large proportion of individuals who are placed in long-term care or waiting for placement in long-term care are individuals who are either not supported in the home, or they're often supported by family members who are burnt out and unable to continue to provide that care. And so as you can see here, in terms of whether or not the resident or the person on the wait list to be placed, nearly over 50% of them actually are living alone and do not have supports at home. But a large proportion, about 1 in 5, actually are living with individuals, but we've downloaded this caregiving burden to the family members, to the care partners, especially of minority populations. And so with the introduction of this legislation, potentially now making it more challenging for care partners and family members to continue to provide care for that older adult, you can potentially increase the caregiving burden and a sense of burnout that many family members might experience as a result. And the other thing that I want to highlight, and I know Dr. Tanuseputro would address this as well, is that when we provide care in an appropriate setting, so in this case, we looked at the experience of long-term care home residents who are primarily Chinese speaking, and their care experience in long-term care and at the end of life. We see that for minority residents or individuals belonging to minority groups, they receive the care with much better clinical outcomes. So in this case, when we looked at reported frequent and severe pain at the end of life, residents who are Chinese speaking residents who are in a language concordant home, so in an ethnic specific home, have lower odds of reporting frequent and severe pain at the end of life. So there are important implications in terms of quality of life, as well as the care outcomes that older adults experience. So one thing that I just want to end on is what Krista had touched on earlier. The process of transitioning into long-term care is not a decision that a person can make very quickly. Typically, it involves not only the conversation with the clinical care team and the patient and their family members, but involves multiple organizations and service providers within the community. And that's generally a conversation that occurs over time, over generally a course of several months or potentially even years, talking about whether or not moving into long-term care is the appropriate care option for this older adult. And this is actually a map that one of my master's students has created based on her conversation with older adult transitioning into long-term care. So this is a complex process that cannot be distilled down to a single conversation that a person has to make very quickly, because otherwise they would be paying $400 a day remaining in a hospital. And so there is now a financial cost to this, the ability to make this decision in an informed manner. So this is really concerning from multiple standpoints. And when we're thinking about what this means for our healthcare system, what essentially this legislation does then is it's now shifting the burden of responsibility from the community into long-term care. which we already know is a strained and overtaxed workforce. So this sector we already know is under-resourced even before the pandemic. But now, because there aren't adequate resources, adequate investment in community-based resources, we're shifting the burden of responsibility into another sector that is under-resourced. So rather than thinking about investment into better integrated care and more community services, this legislation now opens up the door for even further disincentive to invest in those resources, because now you have the policy levers to potentially just continue to think about our older adults as bed fillers or bed blockers, and just putting them in the first available bed. So, the question is this the type of healthcare system that we are trying to build moving forward? So beyond the implication that we see right now, is this the future that we see for our healthcare system and our approach to seniors care?
Thank you very much, Dr. Xu, for this interesting intervention. So we'll now move to our fourth speaker, Dr. Peter Tanuseputro. He is a practicing family physician with a specialization in public health and preventive medicine. He leads the Bureau Center for Individualized Health and is involved in several provincial and national expert panels aimed at improving care for the aging. Please go ahead.
Yeah, thanks, Louise. And thank you again for the invitation as well to speak in this panel. I'm glad Amy brought up those points, because I completely agree, Amy, with a lot of the points that you brought up. I think we're missing the point here a bit, right? I think no one here is arguing against the attempt of the legislation to reduce the burden on acute care. We've all been in acute care. Some of us have worked in acute care. It's a busy place, right? And a lot of sick people need to be treated, and we need beds to treat them, right? And so pushing people out, yeah, at first maybe it makes sense, to put people in places where they could be potentially more appropriately treated. But are we missing the point? Are we not really addressing the true root cause of this issue? And I'm going to show you slides that show that perhaps we are. And I'm glad I didn't actually present. I didn't include slides that shows the impact of ethnic specific or language specific care. But I just want to bring up the point that I really support Amy's last point on ethnic specific homes and language specific homes. That's a crucial part of the long-term care system. And we've published quite a few papers that, showing that language concordant care and ethnic concordant care really leads to much better outcomes. Our last study in CMAJ published, I think, a couple of months ago, showed that inpatient hospital patients, so patients who are admitted in hospital, so seeing people like Samir, if they're allophones, so they can't speak English or French, if they receive care from a physician who spoke the same language as them, so a Chinese patient being in hospital, being treated by a Chinese physician, their chance of dying in hospital goes down by 50%, 50%. And their chance of getting an inpatient harms, so things that can be potentially avoided, like infections or medication errors, go down by 75, 76%. And you translate that into long-term care where decisions are being made in complex patients who are quite frail. You can see how pushing people who might be, who might speak a certain language or who might be ethnic specific, who would, rather prefer an ethnic specific home, forcing them in a place where they're uncomfortable. Is that truly right? Is that a safe, safe practice? Arguably not, right? So I'm going to share my screen before we run out of time, because I know there's other panelists speaking as well. So I'm going to take a step back here and not talk about so much the legislation, but talk about the broader context in which this legislation is happening. And I'm a public health physician, so in public health we always really focus on prevention, right? So once the patient is in the hospital, all hell breaks loose, right? Excuse my language, but it's overcrowded. No one wants to be there if they don't need to be. And people are forced, like Dr. Sinha's colleagues are forced to make difficult decisions. But can we actually prevent that from actually happening first? And I'm going to show you that we potentially can. So let's hope I can advance. This is just an acknowledgement slide for the funders and the other team members on our team. The individuals in this ALC beds in question, I just want to point out again, I think this point has been already made, that a lot of these individuals are frail and many of them are close to the end of life. Some of these patients were residents of long-term care facilities or retirement homes prior to entry. So they lost their bed, or they went to hospital and they got worse. And some were living in the community with home care. So a lot of these individuals could not live independently. And many ALC patients, I don't know if people realize this, but many ALC patients are actually palliative patients, so patients who are destined to be really near the end of life, in their last 6 or 12 months of life. Now, the question obviously then is, is there evidence to show that they shouldn't be there in the first place, okay? But the first thing I'm going to show here, well, this is an analogy. No pun to Dr. Flood's name, but I think one thing that we're trying to do is prevent the flood right into acute care. And what I propose there is that we really should be preventing this this rush of water where there's a lot of chaos in acute care, and really preventing and try to aim to keep people just like Amy said, in the community and well supported. Okay, so I want to bring up this point, and I don't know if people realize this, but the median survival of people in long-term care facilities after admission is about 18 months, right? So these individuals are pretty close to the end of life, and palliative care is essential in long-term care. One of the points of providing palliative care, and I do palliative care home visits for my dying patients, is symptom management and making sure that people are comfortable when they're nearing the end of life. And what I want to show you next is the variation in care that's provided in long-term care, partly because I think we're focusing on some of the wrong things, right? In long-term care, perhaps we should be focusing on the quality that we provide. And I can show you that there's a system here that needs to be sort of paid attention to. So end of life care for long-term care residents, again, a lot of people when they're closing to the end of life will lose their ability to swallow pills. Many will still have symptoms, so things like pain, shortness of breath, or agitation. And a lot of times we give what's called injectables or subcutaneous medications so that these symptoms are well controlled for. And if you can just bear with me, I'm going to follow this logic, and I'm going to show you how this is related to this bill. Okay, so our study, we looked at long-term care residents who died between those 3 years, and we looked at in the last 2 weeks of life, what proportion of patients who died in long-term care actually received one of these medications, okay, one of these subcutaneous medications. And ideally, in palliative care, the vast majority of them should, because a lot of them will lose the ability to swallow and will need that support. And what we did was we ordered the homes, and this is just an example of the medications that we provide. What we did was ordered the homes of the 600 plus homes, and we ordered them from the highest prescribing homes, so the 122 homes here, to the lowest prescribing homes, 126 homes here. And we looked at among all the deaths that occurred in those homes, what proportion of them received any of these subcutaneous medications. Again, these are dying patients in their last 2 weeks of life that really should be getting at least one of these medications so that they are comfortable. And in the highest prescribing homes, we see here that there's 83% of people who've died who received one of these medications. And in the lowest prescribing home, you see the rate here, 37.6%, okay? So what happened to that 50% of people who could have benefited from one of these medications who did not get these medications? I mean, I propose that's a lot of suffering there that could have been prevented. And I'll show you here that, and this is again, going back to the, can we actually stem the flood of patients into acute care, instead of, pushing them out, should we be actually preventing them from coming in? So the Q5 homes, so these are again the highest prescribing homes, Q1 homes, the lowest prescribing homes. And when we looked at the proportion of people, the proportion of decedents that were transferred out to hospital and died outside of hospital, so mainly in acute care, you see that the highest prescribing homes, the homes that are prepared to provide palliative care and provide that symptom relief in the home, 12% of these people who died were died in acute care. when you look at the lowest prescribing homes, so these are homes that prescribe at 37% rate instead of 80% plus, 30% of them actually died in acute care. So look at that, almost a threefold difference across over 100 homes. We're talking about thousands and thousands of people dying, and being sent into acute care, potentially unnecessarily, right? And how many people are we going to force, force quote unquote, with this act? I don't know if it's going to be thousands, but can we actually save that room by keeping people in long-term care, for example? Okay, and this is the variation across LHINs, local health integration networks, and I just want to show this for people who, some of you are maybe planners, just to show that the percentage of prescribing in some local health integration networks are quite high. Those are the green ones here. And in the green areas, you can see that the rates of transfer to hospital are quite low, 10% here in Waterloo-Wellington. And in some regions, the rate of prescribing is quite low. So you see Toronto Central 44%, huge difference, right, in terms of quality of palliative care. And these homes are not, arguably not prepared to provide that palliative care. What are they doing? They're transferring a whole lot more people, 2.5 times, almost 3 times more people into acute care, where potentially could have been prevented from entering acute care. Okay, so I'm just looking at the time here. I'm not going to go through this, but essentially, Canada is quite unique in providing hospital care for people who are dying. So a lot of these ALC patients in Canada, 52% of people die in hospital, and you look at these other countries, and it is much lower. Even the US have a much lower rate of hospital deaths than Canada. And Canada, among all these OECD countries, actually has the highest rate of hospital deaths. So those are long-term care residents who might be prevented to going into acute care. I'm going to just spend 2 minutes here to just show that we can actually be doing the same thing for people who are in the community. This is just another slide showing that the variation in people who died in the hospital varies quite a bit across the regions in Ontario as well. And one of the things that we do, and one of the things that I practice, is home visits for people who are dying. And you can tell here, this is a proportion of people dying in hospital, and people who get no visits from their doctor, almost 60% of them die in hospital. But if you get a visit from a physician, that number goes down to 41% or 35%. So it does make a difference. We can actually prevent these people from dying in hospital. And what I'm going to show you here, though, is that only 20%, only 1 in 5 of people in Ontario who are dying receive some sort of care in the home, whether through a physician home visit or palliative home care. So we have room here for 4 in 5 of people who can reduce greatly the chance of dying in hospital and to end up in acute care and being these bed blockers. The problem, and this is the last slide, it's quite haphazard. Like in Ontario and across Canada, we don't really have a systematic way of providing community-based care to people who are frail, people who are dying in their homes. I'm here in a practice of about 12 doctors in a full family health organization. And if you ask our patients which one of us actually provide home visits, I bet none of the patients will know. Okay, it's quite haphazard to who has that interest, who has that ability, and who's willing to do that. And we have nothing systematic. 4 in 5 do not get home visits near the end of life. Where are they ending up? They're ending up in acute care. Okay, so I think we're a bit missing the point here. Instead of trying to organize this chaos after the dam, perhaps we should be better managing the dam, right? And perhaps we should be managing people better in the community before entering acute care. Okay, I think I'm a couple minutes late. Sorry, Louise. I'm gonna stop there.
That's okay. Thank you so much, Dr. Tanuseputro. Our next and last and final speaker, we're happy to welcome André Picard. He is a well-known health reporter and columnist for the Globe and Mail. He's also the author of 5 best-selling books. And among other awards, he was named Canada's first public health hero by the Canadian Public Health Association. Welcome.
Great, thank you. It's very nice to be with you here today with such a great group of panelists. We've heard some really good presentations about legal and ethical issues and clinical practicalities around this law. I want to talk about something related, I think equally important, but a little different. I want to talk about our vision and our values and what a law like this says about them. You know, as the population ages, what is our vision for elder care more broadly, rather than just long-term care? So in my opinion, I think probably in the opinion of everyone on this panel, most people in society, every elder deserves to live and die with dignity. But we fail quite miserably at this. And I think COVID really drove this point home. The massacre of neglect we saw there just spoke to the ageism and the failure to deal with elders properly. So that needs to be our vision. We all deserve to live and die with dignity. And we need policies and laws that promote that vision. To me, Bill 7, the More Beds, Better Care Act, is the antithesis to this approach. As you heard, it's coercive, and it has many other problems, legal and otherwise. The legislation strips people of one of the most important choices they can make in life, and that's where to live. Imagine if we were told, no, you can't live here, we're sending you off somewhere else. We shouldn't do that to people just because they're sick in hospital. For alternative level of care patients, I think this choice is doubly important because, as you heard, for all intents and purposes, many of them will be moving into the last home of their life. You know, I want to say a few words about ALC patients. We've heard a lot about them because they're being targeted by this legislation. To me, alternate level of care, or ALC, is very much an Orwellian term. It essentially means no care. You know, you get a bed, you get hospital food, but you get no programming, you get no stimulation. You just get the most basic of services. And often you pay for this. You pay a small fee, never mind the $400 punitive one. You pay about $66 a day in Ontario for your food and elsewhere. Living in a hospital is horrible. I've visited many ALC patients over the years. It's a horrible place to live. It's not a life. And this is not a knock on the staff or anything. It's not designed as a place to live. Nobody should have to do that. We have a lot of ALC patients in Canada, one of the highest rates in the world, about 8,000 across the country, many hospitals worth, and more than half of them are in Ontario. I think this number in itself is a travesty of public policy. It's also an enormous waste of resources. People should not be living in a hospital. They end up there because, as you heard, they have nowhere else to go. They're considered too sick to be able to go home, or maybe they don't have a home, but not sick enough to be hospitalized. So they're in this weird nether region. Yet, I think they invariably become sicker because they become deconditioned, lonely, and depressed. Again, because there's nothing for them to do other than lie in their beds. ALC patients, I think, need to be offered viable alternatives and not just be coerced into a specific long-term care home. Being shunted off to a nursing home far from your family doesn't fit the bill for me as appropriate care. In many cases, it's worse than living in a hospital because you're even more isolated. We shouldn't forget either that not every ALC patient needs to be in long-term care. We heard this stated by several panelists. Some would do well in supportive housing, others with home care. Some need rehab, palliative care, hospice care. Some need language appropriate services. There has to be the right place at the right time, the right care delivered. That has to be a key component of our vision for elder care, and I think for healthcare more broadly. In Canadian healthcare, choice is too often a dirty word, and it shouldn't be. You know, the fact that our health system is publicly funded doesn't mean we should have a take it or leave it approach. I don't see choice as a synonym for privatization. Some people use it that way, but we need to have choice within a public system. Having agency, which means having a say in when and where and how you live and how you receive your care, has to be an essential element of good healthcare. Not unlimited choice, not unreasonable choice, but reasonable choice. And I don't think what most people, most ALC patients want is anything unreasonable. Reasonable choice includes choosing the long-term care home you want to live in, if you want to be in long-term care. Now, the province, in its defense of this legislation, has suggested that many people are unreasonable in their refusal to leave hospital. This is why the legislation includes financial penalties, according to the minister. But I think there's actually very little evidence that ALC patients are clamoring to stay in hospitals. The average ALC stay is about 52 days. So is 8 weeks an unreasonable amount of time to find suitable housing for a very vulnerable person? I don't think so. And it's not unreasonable in an environment where we have 40,000 people on wait lists for long-term care beds. You know, sending people to a home that can be hundreds of kilometers away from their loved ones. I'm from Northern Ontario, so I say hundreds of kilometers. That's unreasonable. It's cruel even. And we shouldn't kid ourselves. I know a lot of people on this panel are more polite than me, but you know, why do some homes have empty beds? And it's not because they're known for the excellence of their care. People are being sent to second-rate homes by this legislation. That's the reality. They're not being sent to places they want to be. ALC patients shouldn't have less choice than people living in the community. But I should mention there is a lot of coercion in the community as well. They often give you 48 hours to choose a placement, or you go back to the waiting list. You risk being another several years before a placement. You know, this stuff is heart-wrenching for families. Do you settle for less than ideal or even second-rate care because you're overwhelmed and you just can't do it anymore? Families should not be put in this position. And I think that's one of the things that bothers me about this legislation the most is I think it really is contemptuous of family caregivers. They're the people who do most of the heavy lifting in caregiving. They're essential to life in long-term care and in hospital if you're close to home. So if we make it impossible for a family to have ready access, you essentially deny people care. Again, I think this comes back to the initial, this is probably not constitutional. It's certainly not moral or ethical. Many ALC patients we know have advanced conditions like dementia. For them, moving can be disorienting. It can be traumatic, and it's not a decision that should be taken lightly. Just as importantly, as was mentioned not too long ago, we should be able to decide whether we want to be in a long-term care home or a nursing home at all. We have to deal with things upstream, try and keep people out of these institutions in the first place, including hospitals. In Canada, it's far too often our default setting to go to long-term care because we just don't provide alternatives that are decent. Our home care system, for example, is grossly underfunded and underused compared to other countries. The services just aren't available, and that strips people of an important alternative as well. You know, that's a policy decision, and it's a wrong-headed one to not invest in home care. And so too is Bill 7. Again, I think the worst thing about it is stripping people of agency. The last thing I'll say about this legislation is that it just exemplifies for me how we make policy decisions in healthcare. We do it badly. We do it in a reactive manner. We do it in a short-sighted manner, and we don't do it with any vision. That the population is aging and needs more and new types of care shouldn't be news to any government, yet we're acting surprised that this is happening. ALC patients are entirely predictable if you look at how our system is made and you know how it's structured, which is badly. But we've done nothing to plan for the realities of an aging society, and there are good and bad things about an aging society. As we saw during the COVID-19 pandemic, it decimated long-term care homes. We've had almost 50,000 COVID deaths in Canada. Almost half of those have been in long-term care, a population that just is only 7% of seniors. This is unconscionable to me that we don't realize how our profoundly ageist and contemptuous and dismissive treatment of elders has been deadly. You know, we can do a lot better across the board. I don't think we lack money. We don't lack technology. We don't lack a commitment, at least on paper, but we lack a philosophy, and a philosophy that says we value our elders and we want them to be active members of society. That's ultimately what we should want. I think everyone, with few exceptions, loves their mothers and their grandmothers and their great-grandmothers. We want the best for them. But what we want for our loved ones individually, to live and die with dignity, I think we should strive for collectively. And that's not what we do, but that should be our vision. I think as Canadians too, that we have good values overall, but we need to give life to those values. And it's not with legislation like this that we'll do it. So I'm going to stop there. I look forward to the question and answer period. And again, thanks for including.
Thank you so much, Mr. Picard, for for your words. So we're now ready to put questions to our panel. Before we go through questions that have been, or we tried to go through as many questions as we can from the Q&A. We have two special participants for this will provide very brief comments. Professor Linda Garcia is director of the Life Research Institute at Ottawa U and an expert on aging and dementia. And Ms. Jane Maidis is staff lawyer and institutional advocate at the Advocacy Center for the Elderly, Toronto. Ms. Maidis represents clients in long-term care, homes, hospitals, other facilities, and deals with legal issues in those contexts. So if I could ask both Ms. Garcia and Ms. Maidis, sorry, to perhaps just say a few words, just couple of minutes, so that we can move on to other questions. So we'll start with you, Professor Garcia.
Sure, I won't take very much time because it was such an interesting panel conversation, and I want to give airtime to others. I think the one thing that I would like to bring up, if at some point, is we've been focusing a lot on what's happening with the hospitals in their, les enjeux, what's been happening within the hospitals and the decision making that's been happening there. As a result of what's happened in COVID, we've been focusing a lot on the long-term care homes and trying to change culture there. And I'm very concerned about the people who make decisions about what somebody does not need. So for instance, you do not need acute care, and so therefore you go to ALC. Those decisions, the information that you make to arrive at that conclusion, are not necessarily the same pieces of information you need about what you do need. In other words, when you're going into a long-term care home, we are talking about homes. Our language is different. We're not talking about a patient. We're talking about a resident. We're talking about 18 months, but we're talking about, yes, it's 18 months, as was mentioned by the panelists, in terms of length of stay. Those 18 months are 18 months of living. And that means that's 18 months of being in culturally appropriate, as has been mentioned by Dr. Su, appropriate culturally, but appropriate in so many other different ways in terms of quality of life. So how are we giving people a chance to even change the culture in long-term care, to look at homes, to give those services that are very, very different from what we expect in home in an acute care? And I was wondering at some point if we might have a discussion about that, because the decision making, if we're stuck with this, in addition to all of the things that we need to fight, we also need to fight to make sure that our long-term care homes are indeed homes where we can continue to live, and where those choices and those quality and comments that we need to make, and all of those factors that we need to take into consideration when we're doing this consent, uses the data that we need to have for people to be in age appropriate and culturally appropriate places to allow people to actually live for those 18 months of their lives. I'm entirely in agreement with what has been said so far with regards to, people are not in these acute care hospitals because it's a fun place to be. So if we can bring that other end of the continuum where people are going, and how this legislation will affect that end of the story, I would love to hear some of the panels discuss this as well. I may come back with a comment or later on, but I do want to give the other panelists some time. Thank you so much for this talk.
Thank you very much, Professor Garcia. I will turn to you, Ms. Maidis. There were some questions that I could direct to you as well. So you may make a few comments if you want quickly, but essentially somebody's been asking about the notion of mandatory transfer to secure units is a recognized charter breach, the person states. And is it when we'll consider your charter challenge, is that an aspect that will be part of that challenge? That's one question that maybe you could address.
Sure. Sure. I'll start with that, and then I can certainly, I'm going to make a couple of comments. So no, that is not going to be part of it. You're talking about the detention sections in the Fixing Long-Term Care Act, which were also in the Long-Term Care Homes Act, but which have never been enacted. That is definitely a charter issue and is extremely problematic, not only in Ontario, but across Canada. But it's a separate issue from what we'll be dealing with in the Charter Challenge. With respect to sort of what's going on with the Fixing Long-Term Care Act, I just wanted to make a couple of comments around Bill 7. First of all, the legislation, while it talks about ALC and what alternative level of care, it doesn't really define what that is. And one of the issues is that, you know, different people are going to be defining, you know, what does that mean for different patients? So it's not really clear. Also, when you look at the statistics, it's about 60% of patients are waiting for something other than long-term care. It could be tertiary facilities, it could be home care, it could be retirement homes. And so I think we've heard a lot about, you know, things not being available in the community. But as usual, when things happen, when there's problems in the healthcare system, it's, you know, the frail elderly that always seem to get the short end of the stick. It happened during COVID when they kicked those patients out into long-term care. It has happened a lot. I think that, you know, there's a lot of issues related to this legislation. I think one of the really unclear things is around the choices and what happens if you sort of acquiesce to the hospital or sorry, to the HCCSS, if they're saying, you know, well, you have to go to Shady Acres, and even if you don't want to go there. And so people will say, okay, well, I consent to putting it on my list. And what the outcome of that is that that will become one of their choices. And when they move to that home, they will not get any kind of preference for that home, for moving from that home into a long-term care home. They're going to remain in the same kind of waiting list that everybody else in the community is. They're not going to be crisis. You will only remain in the crisis list if you are never accept, but you don't disagree on the move. So where they come and they've accepted the bed for you on by the HCCSS. So there are issues there. And then just one other thing that I just sort of wanted to mention is that really this legislation is going to backfire, because really what's going to happen is that hospital patients at present are given preference on the crisis list. So there's a crisis list to go to long-term care. It's not as of the date you're on that list. And it's up to the HCCSS to determine who gets the next bed from that crisis list. And the government has made it very clear that hospital patients will be getting those. So if you're a crisis in the community, you are unlikely to get placed from the community. So what's going to happen? They're going to wait for you to have some kind of a crisis in the community, go to hospital, and that's where you're going to get to go to long-term care. So really hospitals now become the conduit to long-term care, which is really the antithesis of what we want. We really need that prevention people have talked about, the services in the community, and the provision of care and other alternatives like supportive housing and things in the community that really aren't available to especially low-income people, that might keep them out of hospital. And so that's really problematic. So I'll stop there, and I can certainly ask there any questions as well.
Thank you very much, Jane. Speaking of hospitals, we have this question, which maybe Samir could answer, for example. So the question is, why did hospital CEOs not push back on Bill 7? And the person asks, do they not have a responsibility to meet the needs of the public rather than the Ontario government? And the question of ageism is raised in that question. So
Yeah.
do you feel you could answer that?
Yeah, I mean, I can't speak for you know what every hospital CEO is thinking. I mean, certainly hospitals are independently governed corporations in Ontario. They're run by their boards and they have their mandates. But when literally 100% of your funding comes from Queen's Park, if you now start saying that you're not going to do what your funder tells us that you need to do, for example, it could make it hard for that conversation that you have to have when you have to say, I want to have money to do this. Because if you're not fulfilling the government's will, then what is your role as a hospital? And the government will say, well, we fund you as a hospital to deliver care. And I've kept on hearing from a lot of hospital officials, Dr. Sinha, we are being compliant. We are complying with the legislation. We are doing what we are being told to do, or we are being, we are complying, with that. And I find that challenging, because all of a sudden, if we say, well, now this is the law, we're just following the law, so that, this is the right thing to do. So, read between the lines there, but it's been very disappointing to see that, we're not going to the fundamentals, that these are human beings. These are our fellow citizens. They actually have rights. And just because the law says that some people are worth more than others doesn't necessarily mean that it's a good law. And I think that's why a lot of us are here today. So that's been really challenging. I think André brought up this idea that one thing I found very problematic, if you watch the media interviews, or I remember when Jane and I agreed to be on the agenda, how many CEOs of hospitals went through they were about to come and debate us, and they said no, we probably went through about a dozen until someone volunteered so we could actually film that episode. And then, of course, that CEO didn't talk anything about the legislation because they didn't want to endorse it. They wanted to talk about, how we should be adequately making sure there's appropriate things in the community so we don't have to force people into places we want. But one of the weird tropes that I've really hated in this entire piece, this point about ageism, is that we've been pitting one group of patients against the others. And you've seen this constant thing like Dr. Sinha isn't, Louise needs a bed. She's in the emergency department. She needs that elective knee replacement. And here's this greedy older person with dementia just sitting in a bed, eating bonbons, and how dare they take a bed when that child, that person who needs a knee replacement needs it. And so almost saying that this patient is worth more than the other, when that person who's awaiting a long-term care placement or they don't want to be there. Yet we're now actually saying that they're the problem. And in other places, they use the term bed blockers, for example, or they almost describe that these individuals are the problem. And now we have legislation to finally deal with this problematic group so that healthcare can run the way it needs to. So a lot of ageism, a lot of ableism, and then a lot of complicit we're just complying with the legislation, Dr. Sinha, as opposed to actually saying whether we agree with it or not.
Thank you so much. That's very interesting. Maybe Amy Shu, we could ask you to answer this question, which states essentially that there are many long-term care homes in Ontario that have long wait lists, and as we know, some 38,000 people are currently waiting, apparently, to go into long-term care. And the question is, under Bill 7, do hospital patients, so the ALC patients, have priority over people waiting placement from the community? So, Ms. Shu, do you feel you can answer this?
I think Jane had already addressed that with regards to hospital patients having higher priority. I think that the point that I was sort of making, I don't know if this is related to my presentation, with regards to those on the wait list, especially, individuals who might be waiting for an ethnic or culturally designated home. I think the fear is that when you get into the crisis placement, then if you are forced to make a decision about being placed in the first home that's available, the time that you have spent waiting for that culturally appropriate home just because you're in the community may then be stripped away. So your right to receive care in the place that you want is essentially trumped by being placed in a hospital because you were in a crisis situation. So I think that's essentially the situation that we're forcing people into, that even though they were well supported in the community, often by paid and family caregivers who are absorbing all that caregiving burden, but now all of a sudden you're in a hospital and all of that is usurped by this legislation.
Okay, thank you for those clarifications. A question here about the 400 per diem that can be collected. So one of the questions is, how will the hospitals collect the $400 per diem? Do we know how many people have been subject to this obligation? How many people have been charged essentially for $400? And So that's, and as well, Dr. Sinha, somebody identified you as maybe somebody who could answer this. Is there any opportunity to use the new long-term care standard to address the concerns raised about overriding patient consent?
So I'll answer the last question first. The the new long-term care standards, which are going to be released on January 31st. I'm proud to say, yes, this wouldn't fit in the idea of what resident-centered care is all about. The challenge is that the new long-term care standards focus on the care that occurs in a long-term care home. It doesn't; these aren't standards to talk about how hospitals would conduct themselves, or even the admission process, into a long-term care home until someone, is coming in to be a resident of a home. So I don't think, to the comments that I saw in the chat there, yes, this wouldn't be concordant with what the long-term care standards speak towards. But the standards talk about the care that is being provided in a home. It doesn't talk about this process here about how people might find themselves placed into a home. From that perspective, in terms of how many people, these have been all the interesting fun facts. It's that there's been a lot of what's been very disappointing is the government has been very select with its data that it wants to provide around Bill 7 and its implications. I think there's been a lot of heroic talk that since Bill 7 was introduced, thousands of patients have been moving from Ontario hospitals into long-term care beds, since Bill 7 was introduced, but not necessarily using that actual legislation. It goes back to that point that Jane said, that right now, when a bed becomes empty, and about 20,000 beds or spaces will open up every single year as people pass away, etc. Now it's much easier to get placed into long-term care via a hospital, because the hospitals not only have priority, for example, but they now also have Bill 7 on its side to literally press the easy button and then send that person along. So yes, thousands of people have been moving through the process, but we also had thousands of people waiting, at that given point in time to be into a long-term care. And as I think Dr. Chu showed, what we've known for a long time, and Kaya has shown this, is that we actually have you're more likely to be placed into a long-term care home from a hospital with a lower acuity status than if you were from the community. So we don't know how many people have been charged the $400 a day. The government has refused to answer the question when it's posed about how many people have actually specifically moved using Bill 7 and that legislative requirement. And because the data is actually left at the level of a hospital simply just sends a bill, and as your bill accumulates, you'll be sent a charge. But I don't think the government is openly collecting that data or wants to collect that data, because it only show information that doesn't necessarily work in its favor. It simply wants to say that we are fixing the system by moving people along. But I think the government admitted recently that they haven't actually freed the overall number of beds. We still have people waiting longer than ever before in the emergency department, despite the implementation of Bill 7. But they're hopeful that you'll see positive effects because of Bill 7 in a few within the next year. It's a gong show.
Thank you so much. Perhaps a question for Dr. Tanuseputro. Somebody wanted to know, what's the evidence that the majority of long-term care clients are palliative? And perhaps something linked as well, is it possible that fewer palliative treatments were prescribed because there was no consent for them, and that transfers are the result of a refusal to consent to palliative care in the home?
Yeah, I mean, we've talked about the 18 months of median survival among people in nursing homes. I think when we think about palliative care, we think about palliative care approach to care. So, and palliative care approach to care, is one that maximizes both length of life, but also quality of life, right? And sometimes, you choose things, or you choose not to do things to maximize the quality of that life, instead of trying to necessarily, maximize length of life, right? And I guess that point, with a median survival of 18 months, I think we all would want our last 18 months to have to be filled with good quality, right? And I think, path care approach to care in long-term care should always be there. In terms of, consenting to path care in long-term care homes versus, wanting to be transferred to acute care, I don't know too many people who want to be in acute care. I don't know too many people who want to be sent to emerge. If you can be comfortable in your home, right? If you're not comfortable in your home, you're in pain, you're agitated, or your relative is agitated, where else are you gonna go? If you don't have that support in a home, whether that's in a nursing home or in your private home, of course you're gonna go to emergency. You're gonna call 911. And I think most people, if they're provided that care, and kept comfortable in the home, and a lot of people aren't, right? And that speaks to some of the issues, I think, of fairness, people being, quote unquote, shipped to homes that are known to have lower quality of care, or that they do not want to be in. Is that really fair when there's such a gradient of quality of care across long-term care homes, right? In many respects. And again, I think we're focusing on the wrong things when we're thinking about pushing people out of hospital. Most people do not want to, these ALC people do not want to be there. I think that was mentioned over and over again. It's not good quality care that's being provided when you're in acute care and you do not need to be there. And a vast majority, I think, of the issue here is not pushing these people out. It's actually preventing them from coming in by providing better resources, not only in the community, but also in nursing homes as well.
Thank you so much. Mr. Picard, perhaps turning to you. Somebody's interested to hear your thoughts on how we can get a better vision of how we care for our elderly. So a fairly wide question, but what are your thoughts on how we can get better care or better vision for the care of the elderly in Canada?
Well, the first thing I would say is someone like, to look to Dr. Sinha. He did a report, I think it was about 10 years ago, about the need for a senior strategy. The blueprint is there. We know exactly what we need to do. I think we just have to do it. You look at countries that have far better elder care than us. We often point to Denmark as sort of the gold standard around the world. They don't do anything magically better than us. They don't have better providers. They don't spend more money, but they just have this philosophy that says we care about older people. And once you have that attitude, the other stuff is just plumbing. So I think it's really about an attitude. It's about a government support. Governments like I think the Netherlands or Denmark, if you treated elders badly in these countries, you'd be out on your duff pretty quickly. And we just don't have that in Canada. In Canada, we tolerate this second-rate status of people. And I think we see that practically in just the number of care homes. We have so many more people proportionally in long-term care homes in Canada. What our care homes look like, they're often hidden out by the highway, old people out of sight, out of mind. When I go to a long-term care home in Denmark, it's going to be beside a school or a daycare. There's going to be interactions. It's actually going to look like a home. It's not going to look like a prison. So it's really fundamental stuff we have to do to have a vision, but it's just about doing a whole bunch of little things and, having a plan. And I think, again, I would point people I'd urge you to go back and read Dr. Sinha's report. I don't know exactly the year, but about a decade more or less in my memory. And it's all there.
Thank you so much. Someone, perhaps you can address that as well, Mr. Picard, but somebody else may want to jump in. Whether it's possible to have standards for long-term care so that the quote unquote scary homes are dragged up to a reasonable standard. So the whole issue of the standards, how can we change that? I don't know if you have a point of view, Mr. Picard, or maybe Krista would as well.
Yeah, I think there's no question we can have standards. We have all kinds of rules. We have rules out the wazoo, but we don't necessarily enforce them. We don't fund them. You can have a rule. We talk a lot about hours of care. So we can have a law that says every resident should have an average of 4 hours of care daily. But if we only fund 3, then we're never going to get 4. So there has to be some coherence to our policies. I think that's what's lacking. I think if anything, our homes are over-regulated. They're badly regulated. I write in my book, I went to a home that had a 91-page list of checklist of things they had to do, but there wasn't a single question on there is, how do your residents feel? Are they happy here? They had things like the temperature of the butter and how high is the bar in the bathroom, all kinds of practical stuff, but it's the important stuff is often forgotten, which is, are people happy? Do they like living there? And nobody ever asks that. That doesn't seem to come into any of our equations, unfortunately.
Turning to you, Ms. James, from a legal perspective and dealing with all these standards or sort of numerous and so on, any insight from a legal perspective on that?
Well, I think it's been said so many times that legal standards are not helpful unless we enforce them. And by enforce them, I don't mean send an inspector into the facility to write a report and warning and then leaving. Like, enforcement means like robust support to make sure that the homes are creating a good place for people to live and meeting all the specific rules. And that is not, when you let people know you're coming in for inspection, like maybe inspections need to be unexpected. But then we need to do more than give people a letter after. We need to follow up. We need to provide the support. We need to check over and over again. And what happens often is that the system waits until things get really bad and sends in a provincial administrator to take over the home. But there were so many warning signs along the way, and they waited until we got to that need for an external administrator to actually kind of take big steps. But rules don't help unless we find a way to enforce them in a way, that changes how things are happening in long-term care. I think another piece that relatedly that kind of is a bit of a challenge in terms of Bill 7 is that there are some great things in the Fixing Long-Term Care Act. And in particular, it has very robust preamble and very lengthy list of patient rights. But I think there's a question of whether some of these new amendments they're incoherent with the list of patients' rights. And there is a little line there in the bill that says, nothing about this bill should be interpreted as being inconsistent with patient bill rights, but it's inconsistent with the patient bill rights, whether or not you had that line in the bill. And I think that, to me, that's really troubling, because we're trying to create with the Fixing Long-Term Care Act a culture where patients and residents' rights are respected and people are treated well. But yeah, we have to sort of walk the talk.
And just, sorry, correct me if I'm wrong, but I believe Bill 7 required an actual legislative amendment to the Bill of Rights as well. So to make sure that the Bill of Rights could be amended with this new coercive legislation.
Thank you for that precision. Ms. James as well, any thoughts, can you expand? And then perhaps we can turn to Jane Midas as well. The discrimination claims on the basis of Section 15 of the Charter. Any thoughts on that? And one question was the following, quote, why then is there no use of copay with other age demographics or other illnesses or conditions? Is it something that you could answer, Ms. James?
Well, I think the first thing I'd say about Section 15 of the Charter of Rights and Freedoms is that although legislation doesn't actually say we're going to treat old people differently than younger people, it's very clear that these provisions are going to be disproportionately impacting older people, frail people, people with complex disabilities. So I would say there's probably an argument that Section 15 discriminates, that this bill discriminates against people both based on age and based on disability. I think it ties into what Dr. Sinha was saying earlier about this kind of narrative of blaming older people for the situation the hospital is in. I think there's this kind of narrative and branding about what's going on that is blaming older people. And now, I don't know if that would be rolled into the framing of how we tell the story of discrimination if and when the Charter challenge happens. But to me, every way that that government has talked about this law has been part of the story of blaming older people, even though the legislation doesn't say that itself. And let's face it, alternative level of care folks are people going to long-term care. The legislation talks about long-term care, and long-term care is mostly it's for people who meet the criteria of long-term care, which means you have to have a need for 24-hour care. And this is mostly older people and old people who are at kind of the later stages of life. So the legislation is going to have a disproportionate impact on those populations, even if it doesn't specifically say we are treating old people and people with disabilities differently. In terms of why isn't the state using these or hospitals using these copay options against other folks? I think it's probably generally they're just really hard to enforce. And I think we'll see probably a story of like how easy is it going to be for hospitals to get folks to pay these bills. I imagine a lot of the people in this situation, they're there because they can't afford private home care. And they got to a crisis position because services weren't available that they could afford. They wouldn't be in the hospital if they didn't have a better option. And so they probably going to have financial challenges in paying hospital bills. I think health authorities are challenged in getting reimbursement for folks from inside and out the province who receive care that, because we don't want to be denying people care in hospitals in Canada, but we can't always collect. So to some extent, it's possible that it's an empty threat. Hospitals are not really going to follow up on because people can't pay. However, it's a terrifying threat that folks don't know how to interpret. If you actually don't have $400 being told you have to pay $400, and maybe you're already in debt for other things, it's a terrifying threat for families who are struggling to support the older people, even if in the end they can't collect. And why they don't collect against other populations who are in the situation, it's probably for the same. It's going to be the same. It's like it's really hard to collect, and people aren't in hospital blocking a bed because they have other options. They're mostly probably there. They have nowhere else to go, and they don't have money to pay for the care, let alone the hospital bed. So
I just wanted to comment because I think that first of all, we have to understand that there's two different things. One is a copay and one is the $400 fee. And those are two different things. So they're entitled to charge for a copay in situations where a person is more or less permanently resident in a hospital, so in a chronic care facility or waiting to go to long-term care. That's what it is in Ontario. And that's allowed under the Canada Health Act. And that's equivalent to about what you'd pay for basic accommodation in long-term care. So those are for people who are living in a hospital or long-term care home. The $400 is a fee. It's what's happening is that they're actually discharging you on paper and saying that you no longer are entitled to be in the hospital. And they have defined the amount. Prior to this, they were already doing this. They were just charging a much, much higher amount. So they were charging often in the range of $1,600 to $1,800 a day, which is equivalent to the interprovincial rate. So they've actually got a lower rate now, but it doesn't matter. $400 or $1,400 a day doesn't really matter to most people because you can't afford it. And what this is really meant to be is a threat to people. And I totally agree with Krista. The hospitals have to collect it. Will they collect it? Will they actually go after it? That's a different question, whether they'd be able to collect it. The families certainly don't owe that money. And if you have an incapable person who's stuck in hospital, is that really ever are they really going to go after that 90-year-old in the hospital sue them for that fee? I think what it is meant to do and what it does is scare people, terrify people. And that is exactly what it's meant to do.
And just to build on that too, it's because I think you may have heard when Premier Ford was, I had one of the reporters challenged with the amount because it was that $1,800 a day that entered into the discourse because the communications lead at one of my hospitals was quoted in the paper saying, well, we charge $1,800 a day when they refuse a bed. And that number certainly gets the conversation going, and remember talking to her and it's like, really, like you had to say that part, right? But that idea, that charge one thing that was interesting in terms of the back to the question about, why are the CEOs not protesting, and how people are saying we're just being compliant with the legislation, we're just complying with that. One of the things that I know a lot of hospitals have said that they appreciate about the legislation is that now, it used to, in the old system, it used to be individual hospitals figuring out a fee and then going out on their own and charging it and saying, we're charging you this rate now. And now what hospitals really appreciate is they can say, it's not me who wants to charge the $400 a day. I'm complying. If we don't charge the $400 a day, we're violating Bill 7. We must charge this if you won't go. We don't want to do it, but if you refuse this bed offer, we're going to have to do it. We don't want to, but we're complying with the legislation. So again, it's these just slight ways of structural coercion to deal with these useless eaters who just won't get out of the way.
Well, I'll turn to Colleen Flood, the director of the health center at Ottawa. Please go ahead, Colleen.
Thanks. I just wanted to kind of come back to the really big picture question that you were asked, Andre, and for others as well, I guess. How do we get to Denmark apart from on a plane that may or may not get there? But how do we get to Denmark? I think we can see the policy initiatives. Many on the panel have spent a lot of time arguing and putting the evidence forward for different kinds of reforms, but they have not happened. In fact, the opposite has happened with this legislation. And one would have thought that, with the terrible figures and the numbers of people who lost their lives unnecessarily in long-term care homes in Canada, that this would have been a moment to really galvanize some change. And yet I think we're not seeing it. So what is it that makes Denmark so different from Canada, and how can we become more like Canada? More like Denmark, or the Canada would like to be. And, I sense that perhaps the impetus might have to come from a charter challenge, that this will have to be where, if it's successful, that this will be the kinds of things that has to be done. But isn't this just a terrible state of affairs that you have to bring a charter challenge to do something just decent and humane? So I'll punt it back to you, Andre, because the big picture question was for you, but I'd love to hear what others think too.
Yeah, I think it comes down to what I hinted at in passing, that I think the public in Canada doesn't vote on these issues. They just we tolerate this indifference to seniors. I don't think that would be tolerated in Denmark. They would toss them out of office. I think that's the big difference, is the politics of people individually. And it's unfortunate. I thought the one good thing that would come out of COVID would be a dramatic change to elder care, and it's been depressing. How little it's been backwards, if anything. We have the Ontario government saying, "Oh, we're going to build more long-term care homes where nobody wants to be." It's depressing. So, but until we make this a ballot box issue, until we're going into the ballot box saying, unless you improve senior care, we're tossing you out in your butt. And we don't do that in Canada. We vote on gas prices or highways, and we always speak a good game about healthcare and senior care, but we don't vote on it.
I think the other aspect is that if you go back to the roots of Denmark's system, I mean, this was about 20, 30 years ago in the late 80s, when they were spending roughly the equivalent of what we were on GDP, and they were saying, look, these healthcare costs are unsustainable, especially with an aging population. So a lot of what there's cultural aspects in Denmark, but more when you actually look at the brass tacks of this, a lot of this is about just being simply practical and looking at the dollars and cents and saying, look, this is not they were having the same conversation we've been having for many years. this is not sustainable with an aging population, and then saying, so what is sustainable? Well, we actually know that caring for people in their own homes, where the infrastructure is already taken care of, is actually cheaper. It's actually in line with what they want. So let's start doing that, where, fundamentally, when Colleen's like, what's the difference, right? Well, they actually put 2/3 of their long-term care spending, and they spend more on long-term care overall, but 2/3 of it goes into providing adequate home and community care services, things that are preventative in nature, but also things that really better respond and provide that support to allow more people to stay in their own homes for longer. So only a very small percentage of the population ultimately requires a long-term care bed. So fundamentally, we're still stuck where the majority of what we spend in Canada is around institutionalizing people versus keeping them in their own homes. So, as André was saying, myself and others, we've all been presenting, like, economically, it's the right thing to do is to have more home and community care. We were just heard earlier in the presentation, only 40% of the people who are ALC in our hospitals are waiting for long-term care. The 60% are waiting for the other parts of the care system that we're not providing. And we already know that many people who end up in long-term care could have been supported in the community had there been adequate home and community care services available. So we know what we need to do. And as André was saying, I was hoping the pandemic would have had this reckoning. It didn't quite. And then we're now going down this legislation. So it might just need to be the Supreme Court that finally tells us enough. And now just start doing what's actually just practical and, frankly, financially more sustainable.